So this is a young person. I think was undergoing evaluation for, I want to say a transplant. I don't remember specifically, but it doesn't really matter. What's cool is the coronary anatomy. So this is a CT angio with coronaries. There's a little bit of motion artifact, but what you'll see is there's the right coronary coming off the right cusp, and you'll see there's a branch coming there between the aorta and the right ventricle that goes into the septum. And then you look, well, here's the left system here, and what we don't see is left coronary coming off the left cusp. So this right is actually supplying the entire coronary system. You can see there's the PDA going distal, the posterior lateral branch coming off, and what is the LAD is really just this branch coming in between here, passing through the septum, and then courses out and then supplies the left ventricle. It's pretty small, but you know, not favorable anatomy at some point in life if you develop a proximal lesion here, of course. And then this particular portion, it doesn't look narrowed anywhere, and there's no really acute angle coming off. But that's one of the, you know, if you have a common orifice, sometimes you get that malignant pathway there. But this one was an asymptomatic one, and fairly young patient. You can see a lot of thymus here. But single coronary system.
Yeah, very nice.
Yeah. All right, this is kind of an interesting case. So this patient has known connective tissue disease. I can't remember specifically if it's undefined or not. I didn't write down the name, so my guess is it's probably undefined. But has these, you know, this clearly has pulmonary fibrosis. But what was striking are these large cystic spaces admixed in with the reticulation and what looks more like honeycomb cysts. And it would not surprise me if this is along the RA spectrum. And, you know, there's that exuberant honeycombing that Jonathan Chung and his colleagues reported at the University of Chicago. But I think this is a little different, though, because these stand out more. So I don't know. You know, I've seen this mixed with NSIP sometimes, some cysts, but I wonder if it's just something to do with the connective tissue disease, or if there's an overlap with like a Sjogren's and there's some protein deposition admixed. Because if you took the fibrosis away, I think one could argue these kind of look almost LIP-ish.
Yeah, interesting.
And they're sort of basal predominant. I'll put them up on the coronal. There we go. So, yeah.
That is curious.
But this pattern of fibrosis, too, it's just not your run-of-the-mill UIP. There's these really just confluent cystic spaces. So when I see that, I think of connective tissue disease, even if I can't give it a pattern name. I mean, it's clearly basal predominant, subpleural, although you got pretty extensive stuff in the upper lobe. So just a very strange case. All right, and then the last case is interesting primarily because I have pathology. So this is a 58-year-old female who had shortness of breath, dry cough, and has this CT scan that was done elsewhere. And you can see it's a lot of motion artifact down low, but you can see there's diffuse central lobular ground glass nodules and just a little bit of lobular hyperinflation and air trapping. You can see a couple areas. As we go down, you see it a little bit more. So a great look for HP. Didn't smoke, so not RB, and really no other exposures. Didn't really have much. It had a mold exposure, I think, was the only one. But what was so interesting is that they did a transbronchial biopsy, and I'll pull up the path. Let's see. And so this is the transbronchial biopsy here, and you can see there's these large rounded lesions, these large granulomata. Yeah, let's see if I can show these here. And what was interesting about them is just how well formed they were. We typically do see some granulomata with HP, and they're kind of just hanging out in the interstitium, and they're loosely formed. And these were more centered on the airways. That's what the pathologist was showing us. And you can just see them, just how well formed these are. They're not quite sarcoid-like, but definitely more than you see in a lot of them. And so, and you can see a little, that looks like a little bit of, almost a little bit of OP in here. There's some plugging. But what our pathologist was talking about is this is seen a lot more with sort of the hot tub lung, where you get more granulomata in the airways, like you might see with a mycobacterial infection. But this patient had no known mycobacterial exposure, no hot tubs or anything. And it's unclear what was causing the HP. So it's one where the path is almost more than you'd expect, but the radiology is so classic that we just call it HP. So we ended up not pursuing an additional biopsy and just calling this and treating it as HP, trying to get more detailed information. But we don't do a ton of biopsies on these anymore. And typically you see some organizing pneumonia, a lot of blue cells around the airways and the loosely formed granulomata, and not these as exuberant ones as this one. So, but it's a pretty good CT example. I think there's a second scan that may have, you can just see the air trapping. I know she's breathing through the scan, but it actually shows the bilateral multilobular air trapping. So I think putting all of this together, it's a pretty classic diagnosis of HP. And I don't think anybody else would consider anything else and pursue a surgical biopsy, and we opted not to.
And that was transbronchial, because it looks like they got a lot of tissue out of a bronchoscope.
Interventional pulmonologist.
Yeah, they went for.
They'll take some.
Jeff, those were really, a lot of those little central lobular things had little holes in the center, so you were seeing little air bronchiolograms in the centers of the lobule. So it's really airway centric.
Yeah,
disease. They're very nicely shown on CT, and you almost don't need the path.
Yeah, I mean, I think this is a pretty classic HP case. Even RB doesn't give you this diffusive nodules. And they're a lot smudgier and typically have an upper zone predominance. But it's one where the pathologist was a little less comfortable with the diagnosis, just because it was they were worried about infection or something else because of the just extent of granulomata in the airways, which you typically don't see. But yeah, that's what they did say with this hot tub lung. So whether hot tub lung, I think from our standpoint, typically looks just like HP, but I think from the pathologic standpoint, it's just the inflammation is more centered in the airways as opposed to around the airways, but it results in a similar clinical picture. Okay, that's all I have this week. It's been mostly just the cancer follow-ups, so not a lot of interesting stuff. All right, who would like to share next?
I can go anytime you like.
All right, I'll make you the presenter.
Okay, this is a patient for whom I do have a surgical lung biopsy. So this is a chronic condition. I'm not entirely sure what provisional diagnoses may have been made in the past, but you can see I have images from 2015 going forward. So this chest radiograph is from 2015. And then I will show you a CT. This is a contrast CT, of course, from January of 2016, showing the diffuse pulmonary hyperattenuation abnormality. It's very extensive. There are, of course, some areas of the lung that are less involved or apparently not involved. And tell me if you disagree, but what is interesting, and I'll show you some follow-up CTs, is that within the areas of pulmonary hyperattenuation abnormality, there are small, very small, well-defined cystic spaces. So let's go forward in time to October of 2018. And I'll just bring up the comparison. Let me just get these non-synced. So I'll just pick a spot there, and you'll see that this looks pretty much the same. Still a very diffuse abnormality, gray lungs, some areas that are relatively spared. And then I think particularly on this scan, we can see that there are small areas like that, multiple of them, that are interesting cystic spaces within the involved lung regions.
Cigarette
I'll
smoker?
leave that. Go ahead.
Cigarette smoker?
Yes. I'll go ahead to a more recent one. So we have different scans obtained at different places, but these are thinner cuts. And at this place, they take a more limited number of images. And you can see that we have the same abnormality, but we don't have findings, interestingly, even a hint of a fibrosing lung disorder that's evolving. Lung volumes may be a little bit different, but that's hard determination to make because I don't know how they scanned the patient. But a persistent, obviously chronic, diffuse pulmonary hyperattenuation abnormality is present over time. So here we have some images from the surgical lung biopsy, so different degrees of magnification. So that shows lots of cells. So I'll go on to here. Actually, this is probably the nicest one. So what is relevant here, and I'm going to make this a little bit bigger, are these super typical smokers' macrophages. So here we go there, 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 and there. So very fine, in some areas maybe slightly more than fine, but mostly fine macrophage pigment, very typical for smokers' macrophages in the lungs. And that's basically what we're seeing, is a very florid or DIP, but the lung is just full of smokers' macrophages. This is a particularly big one right there. So,
wow,
yeah, DIP.
That's impressive.
Yeah, that is very impressive, isn't it?
Did they specify? Well, I guess it doesn't matter where it was taken from because it's diffuse, but has anyone ever figured out, you know, we talk about smoking-related lung diseases being in the upper lobes, but there's descriptions of DIP being more basal predominant.
right.
Yeah.
Has anyone
kind of like this case, maybe?
Yeah. Well, this one's pretty diffuse, but it makes you wonder. I don't know if I mean, it doesn't make sense to me, and I always wondered if those were really DIP cases or how they were interpreted, or if there's something we're just missing.
Yeah. And I've seen this on occasion, and it has been described where in the midst of the hyperattenuating lung, you get these small cystic spaces just of that size and that shape, and I don't know why they occur, but certainly I think well described in cases of so-called DIP, diffuse.
Are they really cysts, or is it just central lobular emphysema that's really being highlighted by all of the surrounding ground glass?
Yeah, I don't know.
I think they're cysts because they're very punched out. You know, they don't have the shape. They don't have the shape of the lobule.
Well, like that one in the left upper lobe that he just scrolled through, kind of. I agree, David, that a lot of them look that, but that one right there kind of looks more like. If you took away the ground glass, you'd say there's a little central lobular emphysema, but.
Yep, I agree.
Yeah, it's hard to know because there are some emphysematous spaces like here, paraseptal, a few, and there are a couple of subpleural paraseptal emphysematous spaces there and there. Right. But the other ones are so round and so discrete. I don't know what that is actually. But one can see that in textbooks. If you look at textbooks that have DIP cases, they often show some that have this kind of thing in.
But so Travis, were you there when Howard showed the chest X-ray at the beginning? Because it really showed the basal predominance very nicely.
Yeah.
Yeah.
Yeah, it's a really impressive case. At what point did they pursue the biopsy? Because obviously
the biopsy is very recent, so they took a long time to do the biopsy. I think there may have been questions about the reliability of the history that they were getting.
Okay.
And so on. So even though she's obviously had this for a long time, the biopsy is just the other day, really. And actually, here's a really nice article that the pathologist shared with me. It's kind of relatively recent, I think, on DIP from the pathology literature. Well, actually, this is from 2011, but it's a nice description of DIP and some of the differential diagnoses. And she kindly sent that to me as well with the slides.
Very cool.
Yeah. So the next case you guys will really like. So before I even bring it up, you need to make a diagnosis right away because it's so classic. I can't conceive of a differential diagnosis. So I'll give everyone a moment to look at that because this is the so-called textbook case. So we have one large rounded opacity that is uniformly white in the right lung, and we have a large rounded but cystic space containing mostly air in the left lung, but there is some opacity or fluid in the dependent portion of this. And for those of you that haven't made the diagnosis, when you see instead of a straight fluid level, now the patient is of course recumbent, is upright, but if instead of seeing a straight fluid level, you see this kind of lobulated appearance, there's really only one diagnosis, I think.
Mm-hmm.
Let's go to the lateral, just to give you, pointing in the wrong direction. Again, there's something right there that's lobulated. So that is classic water lily sign or sign of Camelot for hydatid cysts. So here is the CT and in close proximity to the previous. So here we see the fluid containing cystic spaces. Now we have some interesting findings here. Here you can see what produces the so-called water lily sign on chest radiography. But you can actually see down here some internal structure or membranes in the dependent portion of this. We clearly have air there, but we also have consolidative opacity in the left lower lobe about that. So super typical for Echinococcus cysts with rupture. And we have the membranes lying in the dependent portion of this space, but we also have consolidation in the left lower lobe as well. Now, it's said sometimes in textbooks, for some patients at least, when they rupture, they present very acutely like an anaphylactoid shock kind of appearance. This person did not present that way. He was sent here from Idaho. So you always want to get a history of sheep, dog, man to make the diagnosis. And indeed, he's a shepherd from Peru. So it turns out that not uncommon in the United States that farmers in the West who have sheep do hire as shepherds people from two places. One is Spain, Basque-speaking people who are shepherds, but also from Peru. So undoubtedly, he was a Peruvian shepherd that was hired to tend sheep in Idaho in this case. And I think undoubtedly, I don't know how long he's worked there. So he may have had this when he came from Peru and was employed as a shepherd in Idaho. So here is some information. So they actually took the cyst out, as you can see from the op report. They went in there, they put a needle in there, they drained the fluid, they mobilized the cyst, they repaired the bronchopleural fistula associated with it. The pericyst is actually the host response or the fibrosis around the cyst itself. That is the pericyst. And then they took that out. So we have here the life cycle. We have the water lily sign. I didn't know about the sign before, but some people describe the membranes on CT, particularly in the dependent portion like this, as the serpent sign. I guess in some way these membranes can look snake-like when you image them on CT like that. So we have the water lily sign and we have the serpent sign for that. And yeah, I'm not sure when I'll see another one, but this is a patient from Idaho recently.
Doesn't it also occur in some of the northern woods and the moose and the wolves that hunt them? The sylvatic form.
There's another form of Echinococcus, I can't remember, it's multilocularis, but that may involve, instead of having dogs and sheep, you have other wild animals that are the intermediate and the hosts, or the intermediate and definitive host compared to the classic sheepdog man of Echinococcus granulosis. But I can't remember the details of the other one.
That's a spectacular case.
Yeah.
Beautiful.
Why is it called the Camelot sign? I've not heard that term before.
I can't remember what there was about the Camelot. I have to look that up.
Okay.
I can't remember. I think I used to know that, but I can't remember anymore. I have to look that up. C-A-M-A-L-O-T-E. So yeah, the inner layer, the endocyst, can rupture and fall down at the bottom and so on. And you can also get that sign with the hepatic ones as well, of course. The last one is just trauma patient, just with a curiosity. So if you were looking at the CT in the context of trauma, yes, the patient is intubated, but most of the trauma, actually all the trauma, is not really in the chest. But you encounter an object here, like where did I get it? Right there, and wonder what that might be. Well, the answer has to be somewhere else. And in this patient, the answer is down here, where undoubtedly one of these pellets entered the vein and went to the right ventricle. So huge amount of pellets with a lot of bowel injury from shotgun, I think it was. One pellet got access to the vein and ended up in right ventricle. And yeah. Okay, those are my cases, Jeff.
Very nice, Howard. Beautiful.
Yeah, great cases. All right. Who would like to share next?
I can show mine.
All right.
All right. Okay, you should see my database window.
We do.
Good.
Okay, this first one is something we have seen quite a bit. The story behind this one's a little interesting. Stop. Stop. Yeah, so this is a patient that's had 2 radiographs. These were a couple of weeks apart. She had actually had a study about a year prior to this first one here that was similar. And at one point, this had been called a bacteroic hernia, or most likely a bacteroic hernia on the left side. And you can see, you know, it's a little dense for that. It's a little bit larger, and certainly it goes a little bit lateral. And I don't know why she had a pleural effusion at this time, but the pleural effusion went away. And I think this is the nicer lateral radiograph. And you can see there looks like there's a little bit of lung here. And so at any rate, we raised the possibility that this wasn't just a bacteroic hernia, and that this might be a mass, either pleural or, you know, less likely in the lung. And so here's one of the CTs she underwent. She underwent 2. This is at the time she had a pleural effusion. Again, I don't know if that was related or not to this. I think this was originally an incidental finding, but you can see it's a coarsely calcified mass with some areas of lower attenuation within it. And it's near the lung parenchyma here, clearly not in the lung parenchyma, looking to see if there was any sort of feeding vessel, like this could be some sort of large extralobar sequestration. Didn't see anything here, and therefore thought this was most likely a fibrous tumor of the pleura. I'll show you the post-contrast images, and you'll see here that in fact, yeah, there's no real big feeding vessel from the aorta, and you can see that there's some vessels supplying it from the lung. So even though it's kind of draped posteriorly, it's most likely coming off of the visceral pleural surface, given these vessels feeding into here. So that increased the likelihood, we thought, that this was a fibrous tumor of the pleura. Still wasn't sure, you know, about the effusion. And I know, David, I think you've mentioned in the past that these pleural effusions make you a little bit more nervous about them being malignant solitary fibrous tumors.
Right.
I think that's what you've said in the past. This one they took out, it was a fibrous tumor, but was considered non-malignant. But just it's a weird, it's a little bit of an unusual look, just how lobulated it is, as you can see on this CT, but not a malignant fibrous tumor, but still with a pleural effusion. And we never really figured out why there was pleural effusion there.
The
There's even a bit of pericardial fluid, wasn't it? Seriously.
Say that again?
A little pericardial fluid even. I'm not sure why. Pericardial.
Pericardial, yeah, just a little bit.
Just a little bit. Probably
Yeah, normal volume there. So
So interesting.
the inhomogeneity is another finding that pushes you to think of malignancy.
yeah, but in this case, yeah, good look for solitary fibrous tumor. Some features suggesting it might be malignant, but ultimately it turned out it was not on pathology. And not, I don't know, if you just saw this radiograph, this, one of these and not the other one, I guess it's just, to me, looks a little too distinct and too large to be a Bachelec hernia, but I don't, obviously I'm biased in this case, knowing the answer now. If anyone else has any other words of wisdom to impart.
Yeah, I agree with you. It's too big and it goes too far lateral.
Yeah, and I think this too, you're actually starting to get a little bit of, like I pointed out before, a little bit of a margin with some lung here, telling you it's probably arising more posteriorly rather than inferiorly. So
I mean, it's easy to say in retrospect, but I think there's some high attenuation foci suggestive of calcium, even on that radiograph.
Yeah.
Lucky enough to look and be lucky to see it.
Maybe some of this and that, obviously it's going to be really hard. Yeah. First, this caught my eye being curvilinear, kind of like we would expect with pericardial calcification when you see it on FOSS. See if that was actually, I don't know if that actually panned out to be, it's not really along the entire superior surface as you might expect, but. All right, this next one, this one is pretty impressive. So I'll let you look at this radiograph for a moment. So this is a radiograph from 2015. And obviously there's not one, but two abnormal mediastinal interfaces here. There are several radiographs from 2015, 2017 that were all interpreted at an outside hospital as normal. Here you can see the aorta, the descending aortic interface, and then there's this extra convexity here behind the heart, presumably. But also, I think the other one is right here on the right, and clearly 2 years later, this thing has gotten bigger. There's aorta, there's the lateral margin of this mediastinal lesion. I'll show you the laterals, and you can see that this is in the retrocardiac, what should be the retrocardiac clear space mostly. So it's sitting kind of right in here, this thing taking up too much space. So this was actually discovered incidentally on this CT. It's a little bit of a surprise back in November. This CT being done, this is a gated CTA being done for evaluation of aortic stenosis. And so you can see the size of this thing. It is in fact in the middle mediastinum. The patient had a little bit of aortic valve calcification, but not too much. I'm just impressed at how much mass effect there is on the left atrium at this point. And it's very heterogeneous, but has large low attenuation components to it. It's vertically oriented. My first thought when one of my colleagues showed this, I think we were all kind of wondering, was this some sort of leiomyoma or GI stromal tumor or something arising from the esophagus? But I think you can see the esophagus is distinct from this across its entire course. There are a couple of lymph nodes that bothered us a little, certainly sarcomas arising in the middle mediastinum of any histology really can pop up. And then the next question was how to biopsy this. They actually asked us if we wanted to do a lung biopsy. We said no thanks. Try and get a biopsy either via bronch or via the esophagus. So they did. This was just a follow-up CT showing the exact same thing, really. And anyone want to guess what this came back as?
Is there any calcium in its periphery, even though that may not help me too much?
No, I think there's just vascularity here.
Oh, there's some big vessels superiorly.
Yeah, there's definitely some bronchioles feeding this thing.
There's a lot of necrosis in it, and it's not super vascular, so it ought not to be like a unicentric calcium as an unusual diagnosis, because those are usually much more solid and very vascular.
Think if it has cystic elements rather than necrosis. So this turned out to be a huge neurofibroma, or sorry, not neurofibroma, schwannoma, nerve sheath tumor in the middle mediastinum.
Wow.
So yeah, and that was what their prelim diagnosis was on biopsy, and they just recently removed this. And these nodes were just reactive; they're negative, so there was no involvement. This was just a large middle mediastinal schwannoma.
Do they think it's coming off like a branch of the vagus nerve or something?
That's the thought, yeah, because that was in the operative report from the surgeon, that they weren't certain where it was coming off, but they thought it might be off the vagus. So, and
it's a bit unusual in location, because the big ones we've all seen before that are schwannomas are more anterior in the chest.
Or at the apex.
For example. Yeah.
I know I've shown a couple of large ones up high. David's shown them. I think everybody has seen a few of those. Yeah, this was a surprise. I recently saw a case in the abdomen that looked almost identical to this, and it was a big case of a schwannoma, kind of at the root of the mesentery. But yeah, so I was thinking necrosis as well, Howard. You're right, but it turns out this was just all the cystic elements of the nerve sheath tumor.
Yeah, interesting.
And then this one,
on the frontal projection, just to make another point, if you go back to the frontal projection, and you see the mediastinal interfaces, the other clue to the extent of it is that you can change your mouse setting, window width and window center as much as you like. You'll never get to see a vertebral body, or hardly, because it's so attenuating. Well, you kind of do, but that's another clue to how extensive it is.
Yeah, and there's certainly nothing in the azigoesophageal recess. You know, that whole interface has been effaced right here. But you're right. I mean,
you can see how attenuating it is, but it's how big it is.
But you can also understand. I mean, it just kind of looks like a second aorta if you're not used to to identifying these different interfaces. So fortunately, no harm, even though this clearly had been growing for years. All right, this last one, this is a fun radiograph.
One more comment about that, Travis, is that the lateral view, you should always see a crisp posterior margin of the heart. And the lateral view is impressive because you can't see the posterior wall of the left ventricle.
Right.
So that space nothing should fill up that space, and usually it's an esophageal problem if that heart interface with lung is obscured.
Not only that, you don't even really see the posterior interface of the posterior wall of the IVC. Maybe right here, but but you're right. That not only is the retrosternal clear or retrocardiac clear space completely filled in, it's just and you don't really see that because it's being obscured here as well for the most part. So, all right. Last case. This one's kind of cute. Howard, David, do you guys ever do bronchography? It probably predated you, right?
Didn't predate me.
Almost.
Almost?
I used to hate doing.
Oh, this is a fun radiograph because this was after a swallowing study, and the patient clearly had some issues with contrast going down the wrong tube. As you can see, there's contrast along the left main stem bronchus. And when I first saw this, I was thinking there must be a fistula because you've got the esophagus here, and then you've got this huge collection, plus you've got communication with the airway. But yeah, I'll let you look at this for another second. I think I've got a lateral here too that shows this. Yeah, and you can see in this case, you know, it's like it's a tracheogram right here. It nicely outlines the anatomy of the trachea and of all of these airways in the left lower lobe. So I think the radiograph itself is ultimately the most interesting part of this. This patient had prior radiographs where you can see this was an aspiration pneumonia, presumably in his right upper lobe. And you still see this funny thing right here, which is, I think, an air fluid level within, again, this similar to that other case, you have this abnormal interface here along the right, obscuring our azigoesophageal recess. And so it wasn't that this was actually communicating. And to David's point, we'll look at the lateral here and see, yeah, you don't, well, you're not going to see the sharp margin of the posterior margin of the heart, but here, minus the contrast, certainly you don't see any portion of the heart. So this is all esophageal process. And so this, excuse me, this just turns out to be a huge, presumably, I guess, a pulsion diverticulum here. I don't see, you know, findings to suggest that this would be a traction diverticulum. You know, there's no underlying signs of prior infection along the esophagus. And I guess he has some issues with esophageal dysmotility chronically, but you can see that there's airway thickening in some areas and presumably an aspiration pneumonia in the right upper lobe, even though it's in an abnormal, you know, or unusual location for aspiration. But that was clinically what this was presumed to be. So the, yeah, so just kind of, I thought was a really interesting radiograph. I went back and dug this one up because I saw the CT last year and saw this radiograph from the Swallow study the year before. So just, I thought this was kind of a cute case.
Yeah.
All right.
All right, Jeff.
Thanks, Travis. Okay, Peter or David?
Nothing for me this week.
I don't have anything this week, Jeff.
All right. Anyone else have any cases? Otherwise, we can just adjourn early.
Yeah, I think, no, I don't. I showed 3.
Yeah, no, we're good. All right, well, we'll end early today.
I can show a couple more if you want.
Sure.
I've got, give me one second.
I think you're still the presenter too, yeah.
Okay, I think I paused it, but I can probably resume it. Let me just see. Yeah, here we go. So this is one from last month, and of course, this is the type of patient. This is similar to one that Peter showed. This is a patient who comes in. Now, this one had some symptoms that were suggestive of a diagnosis other than COVID at the time of presentation, but you can see, if you're just looking at this radiograph, there's bilateral lower lung opacities. You might even say some of them look a little bit more rounded. So certainly just on its own, you could say this might be a COVID radiograph. This patient eventually had 4 negative COVIDs, and they asked us, you know, if they needed to do any more. And I'll show you the CT though, and you'll see that there is an organizing pneumonia pattern. It's fairly lower lung dominant. It's much more severely affecting the lower lobes. And this is one where we have, let me just pull up these CTs in succession. So you can see there's nice perilobular areas of consolidation in both lower lobes. And of course, at least one of these is a pulmonary embolism protocol CT, as this patient was progressively dyspneic and had, at this point, had mechanical ventilation. And then here was a few days later, there's some barotrauma, worsening lung injury, organizing pneumonia, more dependent consolidation in the lower lobes. Infection, everything else negative. The big clue on this was that she had had a rash and she had had elevated CPK, like through the roof, for at least a month. So this was a myositis, and this turned out to be presenting with like rapidly worsening acute respiratory failure. Which antibody was positive? I think David's shown the most of these.
Anti-MDA5.
Yeah, this is an MDA5. So I think again, especially in the context of multiple negative PCRs, we have to think about other causes of respiratory failure. And, you know, I'm curious what you guys think, because this is the type of case I think 10 years ago would have just been called like AIP, right? And the autoimmune interstitial pneumonia or idiopathic ARDS prior to having some of these autoantibodies. Do you guys agree with that?
Absolutely.
Yep.
And
I guess the other question is, or go ahead.
I was going to say, I think a lot of what was, like a lot of this undefined connective tissue stuff, you know, the whatever we call it now, the IPAF stuff. Yeah, but a lot of these acute lung injuries were sort of subclinical, well, I guess not subclinical, but not classic connective tissue diseases.
Yeah.
And probably some drug reactions too.
Peter, was yours an antisynthetase or was it a MDA5? That one, the one you showed a couple months ago, right at the beginning of the COVID outbreak?
So when I showed the one at the beginning of the COVID outbreak, that was just an antisynthetase. But then a few weeks earlier, I showed a MDA5. So I did show one a little bit before that. But yeah, it looked similar to that.
And I'll just show, and I mean, I know that Howard loves to show cases of pulmonary edema. I will show this one just because I think it's, you know, pretty remarkable. I think our residents, you know, oftentimes are uncomfortable just coming down fairly hard on pulmonary edema when they're on call. I think that they often feel the need to diff things out. I think in a case like this, you see there's fissural thickening, there's peribronchial cuffing, the heart's a little bit enlarged. On the lateral view, certainly you see the fissures are a little thickened, so subpleural edema, small effusions. You know, I think I'm curious how you guys encourage your residents to read these. I would say most likely edema and leave it at that. Now, certainly this next one, it really blows up, and at that point they get the PECT. And this was another example. Remember, I showed that images in medicine from radiology a couple months ago, that interlobular gradient sign where the edema tends to pool at the dependent portions of the secondary pulmonary lobules. And I thought this was a great example of that as well. In some of these areas, you can see it's almost like fluid, like ground glass fluid levels in multiple different secondary lobules. And I don't remember if this was new onset AFib or what this was, but you know, this was all just edema. The patient didn't have any infectious signs. And this was actually, I think, the very next day. That's annoying. Stop.
So Travis, one other point about that dependent distribution is that and you also saw that it was dependent against the major fissure in the upper lobes. So it's drifting down in the upper lobes and being marginated by the major fissure. So that the fact is edema can move through lung tissue and it settles out very easily. And whereas gunky things like in ARDS, for instance, with diffuse alveolar damage, stuff is more viscous and doesn't settle out the same way. Blood is the other thing that can settle through the lung. So I sort of imagine this wet sponge. If you stand a wet sponge up on its edge and stuff like that, you'll get this gradient of the water in the sponge going down gravitationally toward the. I think the same thing happens with water and blood, but not with pneumonia and not with alveolar damage.
So you get this, like this is an interlobular septum right here where it's pooling within, like on more of a microscopic scale. And I think this is what you're saying is more of it dependently layering on a macroscopic scale.
Correct.
It's kind of, yeah. And then this was the next morning. So this was less than 24 hours later and it's completely gone.
Yeah.
So
very nice.
But I thought, yeah, very pretty case of pulmonary edema. So, okay, Jeff, I will stop there.
Thank you. All right. Well, we'll wrap it up and I'll talk to everybody again next week.
Thank you.
Great.
Yeah.
Thanks, everyone.